My name is John Donadieu from Paris. I am a pediatric hemato-oncologist, and I am also a statistician or epidemiologist, and I am in charge of the French registry for congenital neutropenia in France. WHIM was not my first interest. I discovered WHIM by random because working on a chronic neutropenia, I've been aware of a patient with what is called in medicine WHIM. And so at this time, I have to work to understand what is this disease. I have been also stimulated by colleagues working on CXCR4. CXCR4 is a chemokine receptor. These colleagues are in Pasteur Institute in Paris. The story for CXCR4, which is very important for WHIM, start in HIV. The story about WHIM starts about 70 years ago. The first publication of a case which has been later considered as WHIM has been issued in 1964 in New England Journal of Medicine. Curiously, the same patient has been published twice in the New England Journal of Medicine by two teams, but that's the life. At this time, it is a curious neutropenia. This case has some characteristic which was found later, and there is both a very profound neutropenia, infection, and also a very, very specific aspect of the bone marrow. This very specific aspect was named later yelokathexis, which is a Greek name, saying that it is a retention of neutrophils in the bone marrow. And so you have a profound neutropenia, yelokathexis, and later, in case report, we observe there is warts, a lot of warts in this group of patients, and of course, infection. And the name of WHIM came up in 90 because they put the W for warts, the H for hypogammaglobulinemia, which is not so major, the I for infection, and the M for yelokathexis. From the American point of view or English point of view, WHIM is bizarre as the name of a disease. But that's the acronym of this disease at this time. In the 90s, the disease was described only on the basis of symptoms and biological elementary pattern. But this story crossed the HIV. The HIV came up and the epidemic started in the 90s, the 80s, and there is many concern at this time. But a very curious feature was observed. Some patients can be infected by HIV and they are not getting sick. We name this group of patients long-term survivor. At the end of the 90s, this group of patients there is an understanding of this very specific pattern of HIV. And at this time, it was identified that there is a gate in the CD4 lymphocyte. And one of these gates, there is two gates, but one gate is CXCR5, and the second gate was named CXCR4. And if you have a loss of function of the gate CXCR4, the people who have this polymorphism are not sick from HIV. And so we have this CXCR4, HIV, we have a disease named WHIM, and in the beginning of the 2000s, a team in New York found that WHIM is related to a very specific mutation of the CXCR4. But contrary to HIV, long-term survivor, this mutation was a gain of function. And so if you have a gain of function of CXCR4, you have the disease named WHIM. That's a story. And then a lot of things has been started with this because in HIV, there is a development of molecules against the CXCR4, so inhibitor of CXCR4, because we try to reproduce what has been observed in long-term survival. And so if we stop the gate of the lymphocyte CD4, we can stop HEV. And so we have some molecules named CXCR4 inhibitor. And when WHIM was described as a gain of function of CXCR4, of course, we try to put these new molecules, the CXCR4 inhibitor, to treat. So it's a very short overview of this story, but my colleagues in Pasteur Institute are working on HEV. And so we meet together when we have a few cases of WHIM to try to put all the things together and to have a better understanding. Of course, the first challenge in WHIM syndrome is to find the diagnosis. Even if the WHIM, the name WHIM is something already defined, so you have this acronym, in the real life, the way to identify such patients are numerous, because we know that even if the patient has some biological anomaly, of course, when we meet somebody, when you meet your patient for the first time, you have not all the story in front of you. You have a part of the story, and some patients may have a lot of warts, some patients may have infection, some patients may have a mild neutropenia, and so the symptoms are usually not really specific of WHIM. What became specific is to have this infection, these warts, and also a blood count very specific. And the blood count specific is low neutrophils, but in the same times, low lymphocyte, which is very frequent. And you have hypogammaglobulinemia. So you may have this pattern to make the diagnosis. But at the beginning, the first symptoms are very simple symptoms like infection, like warts. What we have observed looking to the patient is that a lot of these patients have a very specific heart defect, which sometimes has been cured in the neonatal period. The heart defect is a tetralogy of Fallot, so a very specific heart abnormality. Sometimes you see a kid, maybe 10 years old, who have infection and blood test, annual blood test. But when you ask on the medical history, you have this background of tetralogy of Fallot. And if we put all the things together, you have the hypothesis that it can be a WHIM, and you can have the genetic test to confirm this, which is a clear-cut genetic test. If you have this gain of function, there is no doubt it's a WHIM syndrome. With regard to the natural history, I think a patient with WHIM don't feel at the present sick. They feel sick if they have acute infection. They feel sick if they have a cancer, which is threatening for them. But daily, they don't feel sick. And that's a big paradox, because we know that maybe they have a severe infection every 2 years, and between the two severe infections, they don't feel bad. And so we don't want to tell them you are in danger, you are in a compromised situation. So we need to be not diplomatic, but we don't want to get them to get sick in their mind. They have strong mind, but they have to consider that it is somewhere some dangerous situation. And they need to have a good contact with their doctors, not to do too much, but to do a good thing in a good time. In terms of symptoms, the most frequent one is infection. Such patients have bacterial infection. So bacterial infection is pneumonitis. They may have skin infection, like what we call cellulitis, infection of the deep tissue under the skin. And also you may have, after this, and mouth infection, oral infection. And you may have gut infection, you may have arthritis. So profound infection and severe infection. That's the first symptoms. The second symptoms clinically is warts. Warts are not permanent. You may have some flare of warts, but not, I say, not a single wart, but maybe a huge number of warts. Usually we consider warts if you have more than 10 warts in the same time. And if you have these two symptoms, you became in alert. If you have a blood count with less than 500 neutrophil count and lymphocyte with less than 500, it became a strong suspicion of WHIM. I think well, for years we have no solution, and so we try to do the best. Very important to have an early diagnosis. But now we have many solutions to help such patients. So it became important and very clear for the patient to prevent the consequence of repeated infection. For example, such patient may have a recurrent chronic bronchitis, and at the end, they have obstructive bronchitis, which may limit their breath and respiratory capacity. So this is a first group of disease. The second group of disease for which it is important to make the early diagnosis are warts. Again, when we have no solution except to burn the wart, it's not very satisfactory, but now we have better solution for that. The prevention of warts is important because not a single wart, but with time, all this package of warts may transform in cancer, in a kind of in malignancy. And so it became important to make the early diagnosis before the warts turn bad. There is now good reason to protect some life-threatening organs like lungs, also to prevent the possibility of cancer in this group of patients. The management presently available, the first thing is to prevent infection. And there are several ways to prevent bacterial infection. The first way is to use chronic antibiotics, so antibiotics prophylaxis. So permanent antibiotics, that's the first possibility we have. The second possibility is to provide immunoglobulin. So we know that in WHIM, the immunoglobulin, the antibody against many germs, is low. And so we can provide immunoglobulin in a repeated way by subcutaneous injection or intravenous injection. And this is the two main approach we have now in our hands. Of course, if there is warts, we need to follow this warts. Some have proposed to use a vaccine against HPV to prevent warts, but it is not so efficient because of the immune deficiency. And so that's a possibility. Some even have proposed hematopoietic transplantation, but it's a very unusual approach of WHIM. So far in all the literature, in about more than about 200 cases, there is two transplantation in this indication. Most of the patients have been protected against infection with antibiotics, immunoglobulin, and sometimes a vaccine. We recently published a paper on this because we were surprised to see this HPV-related cancer, which is the most frequent one in WHIM. We know that there is a lot of HPV in this group of patients, but we were badly surprised to see that some of these warts may turn in cancer. And this is a genital cancer or anal cancer. And it is a bad way to have a cancer because such cancer should be treated by surgery, by radiotherapy, and it's not an easy way to cure such cancer, which can have some deadly consequence. So we have this group of patients, but we know also, and we have observed also that there is some other kind of cancer, mainly lymphoma. And lymphoma can be related to some virus like Epstein-Barr virus, EBV, which can be the trigger of this virus in this group of patients, like what we call Hodgkin disease. So we have lymphoma, Hodgkin disease, or non-Hodgkin lymphoma. And lastly, we may have some other more rare cancer. But most of the cancer are carcinoma related to HPV and lymphoma related to virus and mainly EBV. So this is a major group of cancer observed in this patient. I can just add that we observed this before age of 40. And before age of 40 is early in life, which is completely unusual to have such high frequency of malignancy before age of 40. And that's a testimony of the weakness of this group of patients with regard to virus and to cancer-related virus. The HPV are not so complex to screen, and I think that women have to be followed by a gynecologist for this kind of cancer. Also, as a physician, you have to look on the critical area, which is the perianal area and the genital area. But it's determinant to have this follow-up or to organize this follow-up. And the second, with regard to lymphoma, it's more difficult because you can just follow the ABV in the blood, like ABV PCR or things like that. But most of them occur in an acute way. So it's not so easy to prevent the lymphoma. HPV can be preventable. EBV and lymphoma are not so easy to prevent. When we look to our cohort, because we have set up a cohort of patients in France, so we collect the information of the different patients followed in France in different centers. We try to collect this information close to the patient. And globally, we observe that life expectation is limited in this group of patients because if you accumulated the infection, the cancer, the life expectation is hampered by age of 40. And so we lost about 1/3 of the patient before age of 40. We lost about 2/3 of the patient by age of 60. It's not death in the childhood, but it is death in adulthood, and this can be preventable. But presently, such group of patients have a limited life expectation, which is a concern, I think. We know since the discovery of WHIM, of the genetic background of WHIM, and also some functional studies that there is a impairment in the CXR release. So if we have this gain of function is antagonized by inhibitor, we observe a recovery of the white blood cells, and we have a good feeling that the long-term therapy with this CXR4 inhibitor may prevent many of the problems for this patient. After a long struggle, we are happy to see that there is a CXR4 inhibitor available for this group of patients. It is registered in US since April, and we hope to have this soon in EU. And it's an extremely good perspective for us. But of course, as a change, we need to have in real life a confirmation that it is a good feeling. But well, let's see. So the genetic disease can be sorted in two groups. There is a deletion in a function or an increase in the function. That's for many genetic disease. Sometimes normal life is between the two extremity, and you have something which can be accessible to regulation. In the case of WHIM, the regulation of this chemokine receptor, this chemokine receptor is very important for the migration of the cells. And more you have an expression of the receptor, the CXR4 receptor, more the cells are inhibited. And moreover, we can say that in this dysfunction of WHIM, there is a strong inhibition of the movement of the cells, and the cells are no more able to traffic, to move against a biological target. And also, the cells are not able to come at rest. And so they are always blocked. So this is the consequence of this gain of function. It's a kind of a frozen cells, and these cells are not able to play the normal roles against germs. And so the therapy which inhibit this gain of function feed the cells and let them act against the germs, and they also against HPV, because it's probably a very key factor for HPV defense. And so that's what is inside the notion, the idea of gain of function.